by way of introduction, my name's Beth Payne. I'm a haematology consultant at University College London Hospital, and I'm an associate professor at University College London. I do a mixture of patient-facing NHS-type work, looking after MDS patients. So I'm the lead for MDS at my centre, but I'm also the lead for the National Cancer Research Institute, or what was the National Cancer Research Institute, subgroup for myelodysplastic syndromes. And our role is really to sort of horizon spec, looking for gaps in the treatment pathway for patients with MDS, and thinking about trials for patients with MDS and how we can better serve you as a population and individually. So today I thought I'd talk to you a little bit about transplantation. I'm going to talk about a couple of trials, one of which we haven't got up and running yet, but we are in the process of trying to get some funding for, and one which is due to start initially for acute myeloid leukemia patients, but it will be rolled out, and the plan is that there will be a sub-study that will be specifically for MDS patients. And so I thought I would probably just start just talking about what is the role of a transplant in MDS. Some of you may have had conversations with your doctors about it. Some of you may have been told that that's not an option for you. But even for those in whom that's perhaps the case, I think it's useful to really understand why and what the role of hematopoietic cell transplantation is in MDS. I'm also going to talk a little bit about changes in the way we assess prognosis for MDS, because that's really relevant, I think, in who we decide to do a transplant on, and which patients perhaps might benefit the most from a transplant. And then I'll talk about the trials that we have sort of in development and about to start. And specifically, I'll talk a little bit about something called CAR T cells. Some of you might have read about CAR T cells in the news, but it's not something we currently have available for patients with MDS, although it's a very kind of novel and exciting way of treating patients with other sorts of blood cancers. And I'll talk about how we might be able to expand that into treating patients with MDS. So what's a stem cell transplant, a hematopoietic cell transplant? So a transplant uses stem cells. Historically, that was from the bone marrow. So your donor would be put to sleep and have an operation and have lots and lots of bone marrow sample taken, in the way that when you have your diagnostic bone marrow sample done, and you take like a half a litre or a litre of bone marrow. But actually, we don't really do that anymore. We use stem cells, which are essentially the component of the bone marrow which is able to develop into red blood cells, white blood cells, platelets, the things that you need to survive from your bone marrow. And to get these, we now give injections. Some of you may also receive those injections called GCSF. That stimulates the bone marrow to produce primitive stem cells. And if we give enough GCSF, those spill out into the circulation, and the person who's the donor can go on a machine. The machine essentially takes off all of the blood, spins it, and takes out the portion of that is the white blood cells, that includes the stem cells, and puts the red blood cells and everything else back. And that takes a few hours. So a stem cell donor now doesn't have to have bone marrow taken. It's a relatively straightforward procedure. And the stem cells usually come from a matched donor. That is ideally a sibling, but it can also be an unrelated donor who can be found from anywhere in the world. There's very comprehensive international network of transplant registries across the world that's easily accessible. And increasingly, particularly in younger patients, we can use what's called a haplodonor. Haplodonor is a half match. So you get half of your genes from your mum and half from your dad. And you've got a 1 in 4 chance that your brother or your sister will be a match because of that. But you've got a 50% chance that any of your siblings will be a match. So you increase your chances of a match if you use a haplo, and you can also use a parent or a child, because your child will, by definition, have half of your genes. it is associated with a higher risk from the transplant. And so perhaps in MDS, we don't use that subset of donors quite so much, but it's increasingly becoming possible to have transplants from less well-matched donors, I think is a fair comment. So the cells are collected from the donor, and at the same time, usually as the cells are being collected from the donor, the patient, you, is getting some chemotherapy that prepares you to receive cells that don't belong to you, that come from another donor. So that's usually lasts about a week, and it consists of sort of standard types of chemotherapy to sort of empty out your bone marrow, but also chemotherapy that's very specifically designed to change the way that your immune system functions. So to stop your immune system from seeing these new cells as not belonging and getting rid of them by its own immune mechanisms. At the end of that's called conditioning, that chemotherapy period. At the end of the conditioning, the stem cells are infused, and that's given like a blood transfusion. I mean, we call it a transplant, but it's not an operation or anything like that. It's given like a bag of blood. And those cells then sort of spend a couple of weeks kind of traveling around the body and sitting down in the bone marrow by apparent magic, and they grow into your new bone marrow, which doesn't have MDS in it. And in a transplant, in most patients with MDS, so that's generally speaking the slightly older population of patients, the transplant historically worked because we gave tons and tons and tons of chemotherapy from which you could not recover, and which was designed to completely remove all of the cancerous cells that were there. But in MDS, we tend to use what's called a reduced intensity transplant, and that's this kind of more immunomodulatory transplant where we make space and we make sure that your immune system is ready for a transplant. But the transplant really works partly from the chemotherapy, but also partly because those cells that have come from a brother or a sister or an unrelated donor, they recognize you a little bit as not belonging. So, you know, the patient isn't the donor, and there is what's called graft versus leukemia effect. So those new cells see your MDS cells, any that are left, because there probably are some left, and get rid of those cells. Now, that's also part of the toxicity of the transplant, because it also recognizes other tissues like skin and lung and liver and gut, and that can be problematic post-transplant. That's called graft-versus-host disease. But part of graft-versus-host disease is the new bone marrow recognizing any residual leukemia or MDS that's there and getting rid of it. So a transplant is a twofold piece. It works because there's chemotherapy to get rid of cells that are there, but it also works by this graft versus MDS process. So that's a sort of, in a nutshell, why we do it and what it is. So why, who, and when do we transplant patients who have MDS? So MDS isn't curative by any other means. The only way to completely get rid of MDS is to have a stem cell transplant. So why wouldn't we give a transplant to everybody? Why wouldn't we just do a transplant? Well, the average age at presentation of an MDS patient is 76. And transplants have three main problems. One is that the transplant procedure itself is associated with a risk of death. So just having a transplant comes with a mortality. And the ballpark figure for that, it would depend on your disease and how fit you are and how old you are and how many other medical problems you have. But the ballpark for an MDS patient is something like a 20% related death from transplant within the first year. Then the second thing is that there are significant potential long-term side effects from the transplant. So that's largely related to what I was talking about, the graft versus host disease, when the incoming transplanted cells recognize you as not belonging to them, and they attack your cells, that skin, gut, liver, can be anywhere really. And those can be long-term side effects. They can happen for a short period of time and go away, or they can be chronic and be essentially lifelong. And then the third big issue is that there is still a significant possibility of relapsing after you've had a transplant. So Again, it's dependent on the disease and how much of your disease you have on board at the time of transplant and what the genetics of your disease is. But the risk of relapse is not insignificant. And so we consider all three of these factors when we're thinking about who's the right person to transplant. Is a patient who has MDS a candidate for a transplant? And if they are a candidate for a transplant, when is the right time to do that transplant? So the usual scenario and the widely held view in the MDS community is that patients should not have a transplant if they have low-risk disease, that it is better to wait until the patient has progressed to a higher risk disease before undertaking a transplant. And this is a historical study that was done in 2004, so 20 years ago now, comparing with those patients who didn't have a transplant for MDS. And if you look, let's just take, for example, at 100 months. Can you see my pointer? Can you see a pointer? Yeah. So at 100 months, if you look at the patients who have had transplants, the low-risk transplant patients, they haven't reached quite 100 months yet, but when they're at 75 months, about 50% of them are alive at 100 months post-transplant. And the same for this INT1, that's the next risk group category. So about 50% of patients who have lower intermediate 1 risk MDS are alive at 100 months. But if you haven't had a transplant, the low risk patients, about 75% of them are alive at 100 months. So basically, it's better to not have a transplant. But if you look at the higher risk disease, at 100 months, there's no high risk patients alive. And there's very few of the patients with this INT2, that's the next high risk category. But if you've had a transplant, there are still 25% of patients, admittedly not that many, but still 25% of patients are alive at 100 months. And this intermediate 2 group, you're looking at about nearly 50%. So essentially, this rather old study suggested that it is better to wait to do a transplant until somebody is at a higher risk of disease than to do it when they have low risk disease. Now, why do we think that is? Well, it's almost certainly because of what we were talking about, that there is a risk of death from the transplant itself. So if you do a transplant in a low risk disease, you've still got a risk of death. But it's 2024 now, so you know, things have changed quite a lot since 2004, since this study was published. And in particular, the way in which we stratify risk in MDS patients has changed quite dramatically. So I'll come on and talk a little bit about that. So that study, there were 4 risk categories. There was low risk, there was intermediate 1, there was intermediate 2, and there was high risk. So there were 4 risk categories. And now we have 6, but I'll talk a bit more about that in detail. Treatments have changed. So we now have azacitidine as standard of care for most patients who have progressed a bit in their disease. It's not changed perhaps as much as we would have wanted it to. We do hope that in the next year or so, we will see approval for the combination of azacitidine and venetoclax, which is a new drug that is standard of care for older patients with acute myeloid leukemia. That study hasn't been published yet, but I know that the company are preparing a submission for the National Institute for Clinical Excellence to try and get that funded. So, you know, watch this space, but one would hope that we will have another treatment. But still, we haven't got lots and lots of new treatments, and there have been a few disappointments in the field for drugs that haven't had the outcomes that we'd hoped in some of the more recent clinical trials. We also know a bit more about the impact of comorbidities. So that's other conditions that are not your MDS that contribute to the mortality and the problems that happen post-transplant. So we're better able to stratify what your risk of having a transplant might be. But there are also new ways in which we are doing transplants, and outcomes do seem to be different and, generally speaking, better with some newer ways of doing the transplant. So as a group of MDS experts, we were kind of asking the question, are we transplanting enough patients with MDS, and are we transplanting the right patients with MDS? Are there patients who we've historically said are low risk, that perhaps aren't as low risk as we think, that perhaps might benefit from having a transplant a bit earlier, now that, for example, our methods are better, our survival is better, our mortality is lower? And can we select out patients that would benefit from an earlier transplant? So things that affect the transplant method and the outcomes from the transplant. So as I've said, you can die as a result of the transplant. So that's the big reason not to transplant these low-risk patients, is that they die from the procedure itself. So if we can get rid of that mortality, then we can improve transplant outcomes. And there are new agents that are making transplants safer. And those also seem to make substantially better outcomes for patients if they are transplanted slightly earlier in the disease process. If you're transplanted earlier in the disease process, you don't have as high a risk of relapsing from your disease. If you wait until you have very high risk disease, we have to then try and get you into some form of remission with azacitidine or chemotherapy, and then do the transplant. If we transplant you earlier, maybe we don't have to do those things, and there's a lower chance of relapse. So this is just a study. It's a bit messy because there's lots of charts on it, but there's a new drug called treosulfan, and this is a study which compares using treosulfan, the new drug, with the older conventional drug, which is called busulfan. And these top two graphs are looking at the survival from patients who received treosulfan compared to those that received busulfan. And the blue line is the treosulfan line. So that's the newer drug. And the red one is the older fashioned busulfan. So the left-hand side graph at the top, this is event-free survival. So that's basically you haven't relapsed and you haven't got serious complications from your transplant. And the blue line clearly does better by 2 years. And it looks consistently that patients who are getting treosulfan are doing significantly better. And similarly, the one on the right, this is also survival, but this is overall survival. So this includes, if you happen to have a heart attack or a stroke or some other non-related cause of death. And that is still better when you look at patients who have treosulfan versus those that have busulfan. So then sometimes the offset of that is that, you survive a bit better, but maybe actually you're still progressing. And those two lines are on top of each other. So in the bottom left, you can see progression is not different, whether you use busulfan or treosulfan, it's the same. And most importantly, I think, really, is this bottom right graph. So that shows the TRM, that's the transplant-related mortality. That's what it stands for. And the transplant-related mortality is much lower in the patients that got treosulfan compared to those that got busulfan. So we think that treosulfan-based treatment before you get your transplant, so that's called the conditioning, treosulfan-based conditioning is probably going to become the standard of care for patients who have MDS or older patients who have leukemia because of these better outcomes and the lower risk of mortality. So then moving on to changes in the way we assess prognosis in MDS. So that first study I showed you where they looked at transplant versus no transplant based on low risk or high risk disease, that was based on this study in 1997, and that's a scoring system called the International Prognostic Scoring System. So that's essentially our oldest system, and that scores patients based on what their blood count looks like, so what their white cells and their hemoglobin and their platelets are, what the blast count in the bone marrow is, and what the cytogenetics are. So that's what your chromosomes look like in the bone marrow. And the chromosomes are divided into 3 categories. And you get a number, and based on your number, you're put into one of these scoring levels. And they separate out nicely, as you can see, that the lower risk disease, this is survival, and it goes right out to 18 years. And at 10 years, for example, if you've got low risk disease, in this older study from 1997, about 30% of people are alive at 10 years. Whereas if you've got high risk disease, everybody's dead by about 3 or 4 years. So that was built upon in 2012. And we got a new classification called the IPSS-R. R stands for revised. And in this classification, there, instead of being 4 risk groups, there are now 5 risk groups. And that essentially used the same parameters that were used in the IPSS. So your blood count, your blast count, and your cytogenetics go into that. But they were split, they were divided up. So your platelet count was divided up into 2 different categories, and your blast count was divided up into more categories, and your cytogenetic score was divided up into 5 different risk categories. And that allows people to be separated out again quite nicely. And you can see that when you now separate out these very low risk patients, they appear to be doing better. So we've selected out a group of patients who do very well here. And in this particular group of stratification, about 40% of patients survive at 10 years in this very low risk group. And then in 2022, so many of you may know that when you have your bone marrow done, we look at the genetics of the bone marrow, but we look at it in 2 different ways now. So we don't just look at how the chromosomes look. That was the older fashioned way to look at it. But we now look at specific genes that are mutated, abnormal in patients that have MDS. And we look at, depends on which hospital you're at and which lab your stuff goes to, but we look at between 30 and 100 genes that are known to have associations with MDS. And that's become routine practice really in the last 5 to 10 years, but it hasn't been part of these risk stratification scores. And so now we have a risk stratification score called the IPSS-M. M stands for molecular, and that's what all of these tests are. They're molecular tests. And it allows us to separate now, instead of from 4 and then to 5, we're now separating out risk into 6 different categories. And again, if you look out at this 10-year time point, the best risk patients, the very low risk patients in this group are now have a long-term survival of 50%. So we're managing to separate people out much more clearly into risk. This is important. So how did they do this? How did this study come about? And how did we assign patients into these different groups? So they looked at about 3,000 patients from 24 different countries. And that's how they got their initial data. And then once they'd devised this scheme to assess people, they then validated it on another 700 patients. They were all Japanese, and I'm not sure why they were all Japanese in the second half. And importantly, included groups of patients who have some rarer subtypes of MDS, which were excluded from the prior scoring system. So they include patients who have an MDS-MPN overlap syndrome. So that's a very small fraction of patients who have MDS, where most MDS patients will have low blood count, but the overlap patients will sometimes have, for example, a very low hemoglobin, but a high white cell count or a high platelet count. So these are patients who have a slightly different phenotype to the average MDS patients. And it also includes patients who have secondary or therapy-related myelodysplastic syndrome. So that's MDS that arises usually as a result of prior chemotherapy or radiotherapy for other conditions, often other hematological conditions, but sometimes other sorts of solid tumours like breast cancer or prostate cancer. And it's based on the diagnostic classification, which came from the World Health Organization in 2016. That has actually changed a bit since this prognostic score came out, but we'll not talk about that today. That's for another day. And they used 152 genes, which is quite a large panel of genes. We wouldn't normally do that, but they found that 31 genes out of that 152 were important in predicting the prognosis of patients. This is not really that relevant, but they used a slightly old-fashioned technique for looking at chromosomes, which isn't what we normally use in the laboratory now. So that's just a sort of caveat, because there are other better ways of looking at that now. So this is just a graph from the paper, which really shows on the right-hand side that the number of mutations, the number of abnormalities that you have in these genes that we look at is actually key. So if you don't have any mutations, your probability of survival is the best. Whereas if the more mutations you have, the worse it gets. So this isn't based on anything other than number of mutations. That's a very crude way of looking at it, but actually it's quite a good way of looking at it if you look crudely. And there are some genes that are overrepresented in the there's only one gene abnormality group, and that's shown over here in this nice little coloured chart. So how do they calculate the risk score? It's very similar to the IPSS-R in that it has a backbone which is almost identical to the IPSS-R. And they did that deliberately so they could make quite direct comparisons between the older scoring system and this new system where we included all of this molecular data. So it includes what your hemoglobin is, what your platelet count is, and the percentage of cells in your bone marrow that look like leukemia cells, the blast cells. And then it also used the same way of categorizing cytogenetics. So that's the chromosomes that they used in the IPSS-R. So that's 5 different risk categories. And then it looked at these genes that we look at, and there were 17 features, which is derived from 16 genes, which are binary. So they're either good or they're bad. And then in addition to those features, the number of mutations is also collected from an additional 15 genes. And the reason I've got a couple of these things in red is because the genes that are in red, at least at my centre, are not conventionally collected. So they may be at other centres, but just to say that there is an issue that not all gene panels are the same. They're not the same between different centres, and they're not necessarily the same as what was in this study. There is a standard NHS-based panel, and that will be modified to make sure that these genes are included. And I think the other thing it's important to say is it was okay if we had missing data. So the group that were doing this study, they recognised that things might be different in Edinburgh compared to Canada, for example. And so they recognised that everybody's gene panel might not be the same, and they built it so that if you didn't have all the information, it would still give you a score. So it doesn't just say computer says no if you don't have everything available. So the key part of this information in our conversation about transplants and risk is that about 60% of patients who were low or intermediate risk in the older scoring system, the IPSS-R, went into these higher risk categories. So most patients were up stratified, so they had a worse outcome in the newer scoring system compared to what they would have come out as in the older IPSS-R score. And for us, that seemed to be perhaps highlighting one group of patients that we could consider doing transplants on that we historically might not have considered doing a transplant on, because in fact they weren't necessarily low risk, they were actually a little bit higher risk. So the questions for our trial that we were looking at were, we were looking to test whether a matched allogeneic stem cell transplant offered at an early stage of disease to this group of patients where they've historically been lower risk, but we think they might have higher risk features, improves their survival and their quality of life compared to what a standard of care would be. So standard of care would be watch and wait, azacitidine, intensive chemotherapy, whatever was suitable for you at that time. And the trial would also be looking at using this new reduced toxicity approach to the transplant with the treosulfan-based conditioning, and thinking about advances in supportive care. So one of those things is thinking about the fact that MDS patients have often had quite a lot of blood transfusion before they come to have a transplant. And we often, and we've had trouble prescribing drugs that reduce that iron burden that you get from multiple transplants. And so that had been built into the transplant protocol as well. So we call this a phase 2 study because we're not comparing A with B directly. And one of the issues with doing a study like this is not everybody has a donor available and not everybody wants a transplant. So the only way we really felt it was legitimate to do this study was to take patients who were eligible, see if they had a donor, and in those that had an available donor, we would offer the transplant. And in those that didn't have an available donor, or who were willing to be involved in the trial but not in the transplant arm, they would be our comparison population. And we would also look at using reduction of the iron burden in patients who'd had a lot of transfusions before the transplant to see if that helped the transplant outcome. And we know that that is the case in patients who have transplants for other things like thalassemia or other inherited bone marrow failure conditions where they get very iron loaded before the transplant. It's very important to get rid of the iron before the transplant in those patients. And then, as I said, you know, we can't sort of randomize patients to transplant or not transplant because we didn't feel that would be acceptable to our patient community. And so we're doing this thing called a trials within a cohort design. So that essentially means that other patients who don't have a donor, who would have been eligible for the transplant but declined the transplant at that point in time because they felt they didn't want to have it, those patients could be randomized, or it could be recruited into the study, and they would be used as the comparisons for the patients who did have the transplant. So the inclusion criteria that we decided would be appropriate for this study would be patients who have lower risk MDS categorized by the IPSS-R, lower intermediate risk, and one or more of the following. The newer classification score of moderate, high, high, or very high. So in those higher risk categories in the new scoring system, but in lower risk categories in the old one. Patients who have a low platelet count of less than 30, or whose platelet count is gradually declining at 6 months post-diagnosis. And patients who have fibrosis in the bone marrow. So that's a subset of patients who have something that's slightly different to a standard MDS, where we don't see any changes in the amount of fibrosis in the bone marrow. And that's based on a number of different studies that show that these additional features can be associated with poorer risk and poorer outcome. Patients also have to have a fully matched sibling donor or an unrelated donor that's fully matched and be aged 18 to 69 years of age. And they need to be considered suitable to undergo a transplant based on an objective frailty assessment. There are a number of those, and any one of those were acceptable as an inclusion for the study. And the endpoint is the event-free survival. So that means that's defined as the proportion of patients who fail to either achieve a response or relapse after they've had a response, or their disease progresses or they die. So that's the list of the different events. And we'd be looking for an improvement in event-free survival for those that had the transplant to recommend a transplant in the future for that group of patients. So that's where we were at with this study. We've done a few costings for the study, which have come out ruinously expensive. And so so far the drug companies have declined to be involved and pay for the study. But we're working on modifying the protocol so we can make it slightly less expensive for the pharmaceutical industry. And we're still hoping to get this study up and running in the next year or two. And many centres have expressed an interest in running the study. So when it's up and running, we will most definitely let our MDS UK colleagues know and make sure that people are aware of the study and whether they might be eligible for it. So lastly, I've just got a few slides on CAR T cells. So CAR T cells stands for chimeric antigen receptor T cells. So these are cells, T cells, so that's part of our normal immune system, that are engineered in a laboratory. And they're engineered to have something on the outside of them. So that in the picture below, the CAR T is the cell on the bottom, and it's got this thing attached to it. And the thing that's attached recognizes something that's on the outside of the tumor cell. So the tumor cell, in your instance, is going to be an MDS cell. But so far, most chimeric antigen receptor T cells, CAR T cells, are for lymphoid cancers. So acute lymphoblastic leukemia or lymphoma. There are some that are in development for solid tumors, particularly in pediatric solid tumors. But very little has been done so far in myeloid cancers, although that we think may change over time. So the cell is engineered such that when this T cell connects to the tumor cell that has the thing on the outside of it that it recognizes, the T cell becomes activated and is able to kill the tumor cell. So it's a cell therapy where these T cells are specific to the tumor. So the way that that can be done is that MDS and AML and lymphoid cancers, all cancer cells essentially have abnormal markers on the outside of the cell surface. In lymphoid cancers, these are quite predictable. And in MDS and AML, they tend to vary a lot. So there isn't one particular thing that's stuck on the outside of an MDS cell that is universal to all MDS cells. And the other thing that's a bit of a problem for this sort of therapy in MDS is that the abnormal things that are stuck on the outside of your MDS cells, many of them are also on normal stem cells. So if you create a cell that's able, a T cell that's able to kill your MDS cell, it's probably also going to kill your normal stem cells. And then you don't make any blood. So then you've got a different condition called aplastic anemia. Now, that's the case in lymphoid malignancies as well. The thing that the CAR T is directed against is also expressed on normal cells. It's just that you can manage without those normal cells. So you can manage without, for example, normal B cells, and you can manage without some of your T cells. But you can't manage without your stem cells. You need stem cells because without your stem cells, you don't make any blood. So that's why it's been a bit slow to come up with a way in which we can use CAR Ts for myeloid cancers. Why would we want to? So that's another question, right? There are other kinds of drugs that can target things on the outside of cells. We have lots of those sorts of drugs already. They are monoclonal antibodies. So we have an antibody called Mylotarg, which we sometimes use in patients who have acute myeloid leukemia, which targets something on the outside of a leukemia cell. And antibodies, why couldn't you just use an antibody, a drug that can do this rather than a T cell? And the reason that these CAR T cells have been used is because they have a capacity to live in the body. They're derived usually either from your own cells or if you've had a transplant from a donor cell. And they can live, they can engraft in the same way as a transplant engrafts. And the normal response of a T cell is that they react to the thing that's on the surface of the cell. So they only expand and kill the thing that they're looking at if they see the thing on the outside of the cell that they are targeting. So for example, let's say you had MDS and you started to relapse and you just had a very small amount of disease, the CAR T would see that, it would expand and get rid of it. So it's a live therapy. And in children, it sort of gained a lot of traction because this is often being used as a sort of bridging treatment before transplantation. There are now drugs that are licensed, CAR Ts that are licensed, that are just therapies on their own, but originally it was used as a kind of bridge to transplant. And that's kind of where we're at the moment with CAR Ts for MDS and other myeloid cancers. So the study that's about to open is called the Matilda study. Just to caveat that this is for AML patients, but the protocol is being developed, which is essentially the same that will be for MDS patients, providing the Matilda study is adequately safe. So the Matilda study uses a triple CAR-T approach, because you might remember me saying there isn't one cell, the thing that's on the surface of all AML or MDS cells. It's different between patients. So 3 different approaches, 3 different things that are on the surface of the cell have been selected. They've got numbers CD33, CD133, and CLL1. They are the names of them. And if you cover all of these 3, you'll get most MDS cells and AML cells. And the goal really is to eradicate disease more effectively than chemotherapy with minimal toxicity and maximal efficiency. And then the idea would be to proceed to a transplant. So this would be a kind of pre-transplant, preconditioning, and then you do a transplant. But the idea is, because it's so targeted, that you're going to target your MDS cells, but then all you're going to have to do is make a little bit of space with chemotherapy for the transplant, and it will be a much lighter transplant. And that would hopefully mean that there's less transplant mortality. And also you'll have less disease on board after your transplant, because you very targetedly got rid of your MDS cells. And then the risk of relapse would hopefully be less. So it's very, very early stages for these. This is a phase 1 study. It's essentially looking at safety, and it will only enroll about 25 patients, but it is about to open for AML at University College London Hospital in the next year or so. And so that's all I have. I've talked for longer than I thought I was going to talk for. I just to acknowledge that Amjad Khan gave me lots of the slides for the low-risk MDS transplant study. He's a consultant hematologist in Leeds, and Sarah Garashian is driving the Matilda study, and she is a paediatric hematologist at Great Ormond Street Hospital, but she's running the study in adults with AML, and she's very invested in MDS because her grandmother died of MDS. So she's very much of the idea that this is something she wants to build for the MDS community.